Hello everyone and welcome. Today we are going to tackle a very high-yield topic for your exams, GIT absorption. We'll first understand the normal physiology, and then, very importantly, what happens when this goes wrong, in malabsorption. These concepts are frequently asked, so let's get started straight away.
Okay, let's start with a clinical scenario. Imagine a patient comes to you with three main complaints: steatorrhea, that's just a fancy word for fatty stools, then night blindness, and finally ataxia, which means they have trouble with balance and coordination. So just keep this picture in your mind. By the end of the session, I promise you will be able to crack this diagnosis.
In medicine, to understand any disease, you first must master the normal. It's that simple. So before we jump into what can go wrong with absorption, let's first see how the gut is designed to be such an absorption powerhouse. We'll start with the basics. It's microscopic anatomy.
So what is the main job of the small intestine? It's absorption, right? And for that, you need a huge surface area. Nature has a beautiful solution for this. Look here. The intestinal lining isn't flat. It has these large folds. On top of these folds, you have these tiny finger-like things called villi. And if you zoom in even more, on each villus there are thousands of microvilli. This whole setup is what we call the brush border. It's this incredible structure that gives the intestines massive area for absorption.
Okay, let's simplify this whole process. We can break down absorption into just three main stages. First, you have the luminal phase. This is what happens inside the gut lumen, where enzymes get to work. Second is the mucosal phase, where the intestinal cells, the enterocytes, do their job. And finally, the post-mucosal phase, which is how the nutrients get into the blood or lymph. We're going to use this simple three-stage framework to understand everything today.
Right, so let's take that framework and apply it to our first big topic, fat absorption. Now I know fat absorption can seem a bit complicated, but it's super important clinically. So let's follow the journey of a single fat molecule, a triglyceride, and see what happens. So within that first luminal phase we talked about, fat absorption happens in three key steps. First, lipolysis, which just means breaking down the fat. Second, micelle formation. We'll see what that is. And third, the actual absorption into the cell. Just remember these three things: lipolysis, micelle formation, and absorption.
Now here's the main problem with fat. Big fat molecules like triglycerides are hydrophobic. What does that mean? They hate water. They won't dissolve, so they can't be absorbed as they are. So the body has a system. First, pancreatic lipase comes and breaks the big fat molecule down. Then, bile acids, which come from the liver, act like soap. They surround these small fat particles and package them into these water-soluble balls called micelles. It is this micelle that can actually get close to the enterocyte and be absorbed.
And this is where it gets clinically interesting. Think about it. What happens if a person has chronic pancreatitis? The pancreas is damaged, so no pancreatic lipase. Step 1 fails. What if someone has liver cirrhosis or their bile duct is blocked? No bile acids, so micelle formation fails. You see, in both cases, fat is not absorbed. And where does it go? Out in the stool, causing steatorrhea.
Now this is a very important point. Have a look at this table. Not all fats are the same. Long-chain fatty acids, which are the most common in our diet, need that whole micelle process we just discussed. But look at the middle column, medium-chain triglycerides, or MCTs. See, they don't need micelle formation, they can get absorbed directly. And this is clinically huge. This is exactly why we give MCT oil to patients who have problems with fat absorption. It's a clever workaround.
All right, so that was all about fats. Now let's switch gears to our next macronutrient, carbohydrates. We'll look at how these complex sugars are broken down into simple fuel for the body. And of course, what goes wrong when this process has a problem.
Luckily, carbohydrate absorption is a bit more straightforward. So, at the brush border, you have enzymes that break down bigger sugars like lactose and sucrose into their simple units, monosaccharides. Now, glucose and galactose are absorbed through a transporter called SGLT1. This is an active process. Fructose is a bit different. It uses another transporter, GLUT5, and this is facilitated diffusion. The names of these transporters are important to remember.
So, what's the most common problem you'll see with carbohydrate absorption? It's lactose intolerance. I'm sure you've heard of it. It's nothing but a deficiency of one specific brush border enzyme, lactase. Some people are born with it, but it's much more common to develop it later in life. So without lactase, your body just can't break down the lactose that's found in milk and dairy. So what does a patient with lactose intolerance complain of? Well, after they have some milk or cheese, they'll get all that abdominal distension, bloating, cramps, a lot of gas, and of course, diarrhea. And why diarrhea? Because that unabsorbed lactose sitting in the gut lumen is a magnet for water. It just pulls water into the gut, causing osmotic diarrhea. In small children, this can be quite serious and even lead to failure to thrive.
Okay, so how do we confirm our diagnosis? The best test, the gold standard, is the hydrogen breath test. The logic is actually very simple and elegant. See, the lactose that isn't absorbed goes down to the colon. The bacteria there have a party. They ferment it and produce a lot of gas, including hydrogen gas. This hydrogen gets absorbed into the bloodstream, travels to the lungs, and the patient breathes it out. And we can measure that. A very, very classic question for your exams.
Okay, let's quickly cover our last macronutrient, protein. We won't go into too much detail, but we will focus on two specific genetic defects in amino acid absorption that are very high yield.
For your exams, you absolutely have to remember these two names. First, Hartnupp's disease. This is a problem with the transporter for neutral amino acids. The second one is cystinuria. This is a defect in the transporter for a specific group of amino acids. And there's a great mnemonic for it, COLA. C-O-L-A stands for cysteine, ornithine, lysine, and arginine.
Okay, so we've talked about the luminal phase and the mucosal phase for fats, carbs, and proteins. Now let's look at that final step, the post-mucosal phase. What happens after the nutrient is inside the cell? We'll look at two very important syndromes here that will tie everything together beautifully.
So, remember that patient from the very beginning? The one with fatty stools, ataxia, and night blindness? Well, here's your diagnosis. A-beta-lipoproteinemia. It's a rare genetic disease. And here's what happens. The intestinal cells, the enterocytes, can take up the fat just fine, but they can't get it out. They are unable to pack the fat into these little transport vehicles called chylomicrons. Why? Because a key protein, ApoB48, is defective. So the fat literally gets trapped inside the cell. And this one single problem explains every single symptom. The fat is trapped, it can't be absorbed systemically, so it comes out in the stool. That's your steatorrhea. Now, if you can't absorb fat, you also can't absorb fat-soluble vitamins, A, D, E, and K. The lack of vitamin E causes the ataxia. The lack of vitamin A causes the night blindness. It all fits perfectly. And the absolute classic lab finding you must never forget is on the peripheral blood smear, you'll see these spiky red blood cells called acanthocytes or Spur cells.
Here's another important post-mucosal problem. It's called intestinal lymphangiectasia. Just look at these pictures from an endoscopy. You can think of this as a plumbing problem. The lymphatic vessels, which are supposed to carry the fat away, are all dilated and blocked. You can see these white spots here? Those are the swollen lymphatics. So even if the cell makes the chylomicrons perfectly, these transport trucks have no road to drive on. They get stuck and they leak back into the gut, along with protein. So you end up losing both fat and protein.
Whew, I know that was a lot to take in. So let's do a quick rapid-fire recap of the most important points that you absolutely must remember for your exams.
Number 1. You see a patient with bloating and diarrhea after having milk. What should you think of? Lactose intolerance. And what's the test? The hydrogen breath test. Simple.
Number 2. You see a triad of fatty stools, ataxia, and acanthocytes, those spur cells on a blood smear. What's the diagnosis? A-beta-lipoproteinemia. Lock that in.
And to finish, I'll leave you with a question to think about. Imagine a patient has fat malabsorption because they don't have enough bile acids. Based on what we discussed today, what special type of fatty acid could you give them in their diet that would get absorbed anyway? Think back to that table we looked at. I really hope this session